mesenchymal stem cells. Now, mesenchymal stem cells are very interesting because they are known for their immunomodulatory properties. They can bring down inflammation, very strong anti-inflammatory properties these cells can have. They can differentiate into multiple lineages. They are known to, good MSCs also have, and you differentiate them to show that they have the stemness properties into 3 different lineages. And once you confirm that, then we can infect them with mycobacteria, and these mycobacteria are labeled with GFP, so you can actually track the fluorescence changes, and you will see that there is massive increase in GFP fluorescence in infected mesenchymal cells at 6 days post-infection. And in fact, the bacteria keeps growing inside these cells even at day 15 and day 18, and they don't die actually. That's amazing. So it provides really beautiful environment to the bacteria. And you can do the same thing with CFU, which is a more acceptable way of looking at bacterial growth inside the inside any cell types. While it's these cells doesn't, it's not like they don't have antimicrobial activity. If you use BCG, which is the vaccinate strain and which is the kind of compromised strain, so BCG doesn't survive inside these cells that efficiently, and it gets cleared off. This pattern actually of RV in stem cells look very similar to macrophages. The only difference is the fold chain in macrophages is very low, 2-fold, but in stem cells, this can be 50-fold. So it just kind of provide amazing environment where bacteria can survive. So having said that, we looked at whether MTB infection affects by some means the stem cell properties of these ADSCs, and we did differentiate it into different lineages, and it turns out that they have no effect. We also did microarray, and microarray also showed that none of these differentiation pathways actually get massively regulated upon infection, suggesting that MTB infection really doesn't affect the stemness property of these stem cells. So going back to from where we started this work, trying to understand whether they provide some sort of help to mycobacteria in tolerating drugs. So we set up this experiment where these cells were infected with MTB, and after 3 to 9 days, they were treated with drugs for 24 hours, and then bacterial CFU was calculated. And you can see that, on day 9th with isoniazid, 3 different doses, and rifampicin, multiple doses, you can see nice killing of these bacteria within these stem cells. Well, this was good that they are getting killed. When we calculated percent tolerant population, that is when you compared bacterial CFU in the absence of drug with respect to in the presence of drug, you see around 10 to 15% bacteria were always tolerant to isoniazid at any of the days post-infection that you look at. Similarly, a good amount of drug-tolerant population was seen against rifampicin in these cells. In parallel, when you do in THP1 macrophages, you will see that very small fraction is actually 1 to 4%. The SDs are actually huge because most of the CFU wells will be 0, and then some of them will show 1 CFU leading to very high SD. But more or less, it kills most of the bacteria in THP1 macrophages, but not in stem cells. So what this suggests that MSC resident MTB are tolerant to drugs. So we actually went into multiple directions, and I would certainly not talk about that. But we came up to this conclusion that probably efflux pumps are playing some role in stem cells. And the reason was very clear because in a lot of cancers, tolerance to anti-cancer drugs has been attributed to presence of mesenchymal stem cells, which express huge amount of these efflux pumps, which can throw out the drugs and then kind of provide the tolerance. So we looked at expression of some of these pumps, and we actually looked at 10, 12 of them through real-time PCRs, and 2 of them were really stood out, like ABCC1 and ABCG2, which showed almost MOI-dependent increase, and then we confirmed at protein level of FACS. Doing Western blot was really, really impossible because of their mobility on the gel. Then we used efflux pump inhibitors to see that whether by inhibiting efflux pump can we affect the drug tolerance. And you actually see if you use novobiocin, which is ABCG inhibitor, or MK571, which is ABCC1 inhibitor, you can actually reduce the percent tolerant bacteria. And similar result you can also get if you knock down these efflux pump by siRNAs. You can use ABCC1, 2, or combine, and when you combine both of them, you get additive effect, suggesting that probably these are working in independent manner. We also had some weird result, and I will not discuss too much about it, that when we knocked down these efflux pumps and there was no drugs, there was actually an increase in bacterial population, and we are still following it up, actively trying to understand what does this means. So While doing that, since our lab also works on autophagy, that's one of the major components. We looked at what happens to autophagy modulators and drug tolerance, and all the conditions will lead to inhibition of autophagy, kind of control the tolerant population. So bafilomycin, 3-MA, chloroquine, in all these cases, you see reduction in tolerant population, but not in dapamycin. And all these conditions actually led to better bacterial survival, suggesting there is something very, a crosstalk between the bacterial killing and drug tolerance in these cells. Drug tolerance is also known as macrophages. In fact, this paper, which came in 2016 from David Russell's group, it talks about bacteria which are present in immune-activated macrophages are tolerant to drugs. And he has shown about IFN gamma and TNF-alpha. They can actually make the resident bacteria tolerant to drugs. So we kind of just verified that in THP1 model that we had. We treated them with IFN gamma and TNF-alpha. So you get massive increase in drug-tolerant population, even in THP1 macrophages. But in the absence of drug, they can actually kill the bacteria with IFN gamma and TNF-alpha. So it followed what David Russell's paper showed. So the next target was to see that what happens in mesenchymal stem cells. And as expected in macrophages, you see similar way increase in tolerant population of IFN gamma and TNF-alpha treatment. And surprisingly, while in THP1 macrophages, these two treatments lead to killing of bacteria, in these stem cells, they do not kill MTB, rather bacteria grows well. Now, there is no report in literature which suggests in any environment, IFN gamma or TNF-alpha could have pro-bacterial effect. And I mean, this was really perplexing result to us. And I mean, you can only ask my student to realize how difficult it was for her to convince me that this actually is happening. So we ended up doing utilization studies where we utilized IFN gamma and TNF-alpha with this IFN gamma receptor 1 or anti-TNF to show that the effect on bacterial CFU because of this IFN gamma and TNF-alpha can be rescued if you neutralize these cytokines, suggesting that those effects are A, specific, and B, they require signaling through these IFN gamma and TNF-alpha receptors. And the same thing can also happen in THP1, just kind of validating the finding. The other interesting aspect of this work was we looked at different compartments inside the stem cells where the bacteria can be present, because there's something which is fundamentally known in the macrophages, that bacteria can block the fibrosome maturation pathway. So what is happening in these stem cells? And we looked at LAMP1, lysotracker, cathepsin D, all these compartments. We also looked at RAP5 and RAP7, which are early compartments, but there was nothing very exciting about that. So, so what we see that for majority of conditions which led to better survival of mycobacteria like IFN gamma, TNF, and MK is ABCC1 efflux pump inhibitor. So in all these three cases, localization to lysotracker, LAMP1 or LAMP1 lysotracker, which is actually kind of activated lysosomal marker. So it actually shows tapering down. So there is less co-localization to these compartment. But when you look at BCG, you see very high co-localization, suggesting that the bacterial killing in stem cells actually follow almost same mechanism as in macrophages through phagosome maturation and lysosomal fusion. So just to summarize quickly what we covered so far is that MSCs provide a niche to MTB. MTB tolerates drug more efficiently within stem cells. They have active lysosomal killing mechanism, and inflammatory cytokines have pro-bacterial effects on MSCs. Together, it suggests that stem cells are really kind of preferred site where bacteria would like to go and survive for its long-term persistence, which was something reported earlier. So, of course, we were more interested to understand, how stem cells are providing these really beneficial, environment to the mycobacteria. So we went back to the literature on stem cells, just trying to understand that how it executes its immunomodulatory functions. And what we know about it is that stem cells are known to produce a lot of these immunomodulators. And majorly, these molecules are PGE2, IDOs, IL-10s, and nitric oxide and IL-6. And what they do through these mediators is affect the functioning of T cells, B cells, NK cells, monocytes in terms of their maturation, differentiation, proliferation, activation, all those things. While this part is really very well characterized in literature, what we are talking about is bacteria which is present inside the stem cell. So that cannot be described by this. For that, you need something like this, some sort of autocrine effect of any of these modulators, whether something like that is happening or not. So we went back to our microarray analysis that we had done from MTB-infected stem cells, and we looked at major pathways which are regulated, and some of them were actually inflammatory responses and immune responses. And one of the molecules that came out from that, not one actually, quite a few of them, which were massively regulated, were these. You know, this PTGH2 is almost 80-fold. IDOs are almost 70, 60-fold. You know, it's massive increase. Log2 changes, so 8-fold is like many, many folds. So all these immunomodulators, which are known mediators through which MSCs kind of temper down the effect of T cell, activation of other immune cells, they are very highly expressed in cells which are infected with mycobacteria, suggesting that they are playing some role there probably. And to do that, what we did first, we looked at PG2 levels in the culture supernatant of cells which were infected with mycobacteria, and you see massive increase in the PG2 levels upon RV infection. And celecoxib is the specific COX inhibitor which can block the PG2 synthesis. So in the presence of celecoxib, you see complete loss of PG2, suggesting that the assay has worked beautifully well. So if PG2 is doing something, then you can actually inhibit PG2 by celecoxib and try to see that what happens to bacterial survival within these cells. So what we show here is that this is a control cell where there is no treatment, and with hyphen gamma, TNF, and MK, where you see increase in CFU. But then at 50, 150, and 250 micromolar doses of celecoxib, which is the COX inhibitor, actually you can negate all the positive effects of these cytokines and bring them all down, and you can actually kill the bacteria inside very efficiently with the celecoxib doses. So celecoxib is a drug, so we also confirm the same thing with COX-2 siRNA, and you can actually get very similar result. And we also confirm this using an inhibitor which is called PF04418948. So what this inhibitor does, it actually inhibits the EP2 signaling, so suggesting that the receptor signaling through EP2 receptor is actually involved in the PG2 mediated beneficial effect of these cells on mycobacterial survival. And what we did earlier with hyphen gamma and TNF, if we use the celecoxib, PF, or COX-2, in all these conditions, there was an increase in localization to lysotracker, LAMP1, LAMP1 lysotracker plus CAD compartment. All of them are marker of activated lysosomes, suggesting that the killing again by PG2 modulation, the killing is actually happening via lysosomal degradation. That's the amazing part about it. And finally, we also looked at the bacterial tolerance, because that's where we started. And actually, it turns out that if you inhibit PG2 pathway, you also block, reduce the bacterial tolerant population inside these macrophages, suggesting that there is some linkage between these two, although we still don't know how exactly these things are happening. So what we showed so far, that PG2 acts in an autocrine manner to ensure conducive environment for MTB in stem cells, and that helps drug tolerance and immune evasion. Finally, what we did is we wanted to just assay same thing in vivo. Now, the problem is that we can't do this kind of experiments in humans, so we went back to the mice model, and because all the data in humans were already in the primary cells, so we used the, we infected mice with 100, 200 bacilli, followed for 4 weeks, and then followed up for additional 4 and 8 weeks with treatments like isoniazid at very low dose. It's not a very high dose in a standard dose treatment. Then celecoxib and isoniazid plus celecoxib, and looked at bacterial survival. So this is the standard growth, and while since the INS dose was not very high, so the killing was very, very controlled. Although you could see almost a log killing by isoniazid, and with the COX there was not massive difference here at the whole lung, CFU that you got. But in spleen there was very nice effect, because in spleen what you see is that the purple one is both celecoxib plus isoniazid. The killing is much more efficient than any of the treatment alone, either celecoxib or isoniazid alone. So it looks like it's working in helping the effect of anti-TB drug. So next, of course, from where we started, we thought let's sort out different population from the lungs of the infected animals. So we gated the population, sorted mesenchymal stem cells and macrophages from the lungs, and then we got very good purity of 90% and higher. And we looked at their population and how the bacterial population residing in these sorted cells upon different treatment. So this is how the bacterial population of macrophages varied over time. And if you look at the bacterial survival inside it, so this is the control which shows higher by week 12. And then all of them comes to almost same level, whether it is celecoxib alone or plus INH alone or INH plus celecoxib in macrophages. But if you look at the stem cells, it looks amazing because this is the population, and you have a lot of bacteria present in stem cells inside the infected animal's lungs, suggesting that they are probably actually, whatever the data that we generated are correct, because once they are inside the stem cells, they can probably stay there for a really long time. And you could see very nice effect of celecoxib plus isoniazid here, while isoniazid alone is quite high, but celecoxib is able to bring it down, suggesting that if you combine these two treatments, you are going to get much better efficacy of bacterial killing. And of course, it requires to be done with the whole HREJ combination to see how much increase in efficacy it can bring in. And of course, we have used only one dose of celecoxib. We don't know what happens if we change the doses. And finally, we also verified their presence in human tissue granulomas, like this is from lungs, from lymph nodes, and from ITV granulomas. And the pathologist is still kind of making this figure look better because it is dual staining, but the other stain doesn't look very good. The CD73 stain hasn't come out that well, but he sees that he can see CD73 and anti-MTB antibody coming together, but those are not very clear here. But what we can say so far is that since we have used different tissue granulomas also, that both pulmonary and extrapulmonary TB, CD73 cells could actually be the very decisive player in determining the outcome of drug treatment. And I'll just summarize what we just talked about. What we already knew that these cells get recruited to TB granulomas. They are site of bacterial drug tolerance, but dormant bacteria. But what we add here through this study is that they provide drug tolerance, they provide tolerance to inflammatory cytokines, and thereby they can be probably the preferred niche for mycobacteria inside these cells. This already is in bioarchive, it's getting reviewed somewhere. But I'll just end with this slide, and this is something which is unrelated to drugs but related to vaccines. Just based on what we just discussed, if you look at all the anti-TB vaccines which are under different phases of development right now, so it's all summarized here, phase 1, 2, 3, and 4. They all target different mechanisms through which they want to achieve vaccine clearance. But if you look at the mechanism that they try to achieve, they all have the same common mechanism. They want to make high IF and gamma producing CD4 and CD8 cells. Now imagine if that's the scenario, these vaccines will be able to control bacteria which is present inside the macrophages, but they will really fail to control anything which is present in stem cells. And we know that a lot of bacteria are present in stem cells. And we can ask the question that is the reason why most of the vaccines are failing in trial, especially at the later stages. And I'll stop here and leave with you guys with this question to think about. And I will thank my people in the lab. So Niharika is the student who did most of the work, with several collaborators, of course, and funding from a lot of places. And thanks for your patience.
Thank you. Thank you, very nice talk. Yeah, a little bit short on time. One question eventually. Yes.
So thank you, Dhiraj. That was a really interesting presentation.